Tracheostomy demonstration by senior clerk Concepcion. Tracheostomy refers to the creation of a communication between the trachea and the overlying skin. The opening made will close spontaneously once the tracheostomy tube has been decannulated. Indications for tracheostomy include upper airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, treatment of obstructive sleep apnea, and prolonged mechanical ventilation. Materials needed: syringe and anesthetic, forceps and gauze, scalpel and tissue forceps, needle holder and silk suture, surgical suction, electrocautery, retractors, and tracheostomy tube. Step 1. Preparing the incision site. Place the patient in a supine position with the neck extended by the pillow or bag placed under the shoulders to deliver the trachea out of the thorax and to be adequate access to the cervical trachea. Then palpate and identify the surface landmarks starting with the thyroid cartilage, cricoid cartilage, and suprasternal notch. Then 2 finger breadths from the sternal notch, mark a line for incision. Sterilize the skin of the anterior neck and chest, and then drape the patient. Step 2. Infiltration of anesthesia. Unless the patient can safely be intubated or the patient can be ventilated with a mask, a tracheostomy should be done under local anesthesia. The skin, soft tissue, and trachea should be infiltrated with local anesthesia with adrenaline before induction. Remember to change your gloves after infiltrating the anesthetic and use the sterile gloves before making the incision. Step 3. Incision. Make a horizontal incision along the marked line through the dermis. The subcutaneous tissue is then dissected using electrocautery. Intermittently palpating the airway at this point is important as it is easier to stray from the midline. Once the fascia has been cleared, identify the strap muscles and retract them laterally. Then expose the trachea by carefully parting the overlying soft tissue with a pair of scissors. Tracheostomy is done between the second and third tracheal ring and then extend it to an appropriate distance. Then create a Bjork flap for tracheostomy tube changes. Step 4. Suture the flap. Reflect the Bjork flap inferiorly and suture the flap to the skin. Step 5. Inserting the tube. Then insert the tracheostomy tube into the tracheostomy atraumatically that comfortably sits in the tracheal lumen. Secure the flanges of the tracheostomy tube and pass them around the neck. Tie them with the neck flexed. Complications of the procedure. The complications of tracheostomy can be classified as intraprocedural, early, less than 7 days, or late, more than 7 days. For intraprocedural complications, it includes airway fire. Despite being a rare complication, it is commonly found during tracheostomy. The drapes, ETT, and alcohol-based antiseptics are our potential fuel sources. Bleeding. Intraoperatively, most bleeding is secondary to anterior jugular vein injury or from bleeding edges of the thyroid. Pneumothorax or pneumomediastinum, which may be due to direct injury to the pleura or dissection of air along the trachea or rupture of an alveolar bleb. Early complications include infection, tube obstruction, which comes from the obstruction of the insipated secretion due to the loss of natural warming and humidification of the airway, causing drying of tracheal mucosa. Accidental decannulation, which may be associated with patients with altered mental status, increased secretion, and nursing shift changes. Late complications include tracheal stenosis, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula. Thank you, and please subscribe to my channel.